Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Today, we're delving into the complexities of ANCA-associated vasculitis, and I've brought in a formidable guest, Dr. Tanaz Kermani, Director of the Vasculitis Program at UCLA. Together, we'll explore the many challenges that come with diagnosing and managing patients with this rare autoimmune disorder. We'll discuss how to interpret ANCA serologies in real-world practice, how to select induction treatments for critically ill patients, such as when to use rituximab versus cyclophosphamide, as well as addressing the role of avacopan as adjunct therapy. We'll tackle some of the hardest questions clinicians face in vasculitis care, like when to consider plasma exchange, how to manage steroid tapering, and we end on a discussion of patient registries and how they have significantly advanced our field. Dr. Tanaz Kermani is an internationally recognized vasculitis expert and clinical professor in the Division of Rheumatology at the University of California, Los Angeles. She completed her residency and rheumatology fellowships at Mayo Clinic, followed by an additional 2 years of vasculitis training as part of the NIH-sponsored Vasculitis Clinical Research Consortium. She's the founder and director of the multidisciplinary UCLA Vasculitis Program. She's a full-time clinician and active researcher participating in multiple international collaborative endeavors in vasculitis. Enjoy. Tanaz, welcome to the show.
Hi, John. Thank you so much for having me.
So, last week I was teaching medical students about vasculitis, and we make the point that often it's helpful to get a biopsy so that you definitely know that it's vasculitis. I'm wondering, what challenges do you face when diagnosing patients with vasculitis? Because often a biopsy may be really challenging or difficult or not possible, or sometimes patients decline biopsies in these cases.
Yeah, so I think a biopsy is helpful because sometimes we do see positive blood tests and serologies, even in other autoimmune diseases, infections. So in general, whenever we can, it is helpful to have a biopsy to confirm the diagnosis. It also depends on what sites are affected. So a kidney biopsy is readily available. Skin biopsy is probably the easiest. Things like sural nerve biopsy or nerve biopsies, lung biopsies might be more involved, and it might be helpful to discuss with the other specialists as well regarding the yield, taking into account the entire clinical picture.
Yeah. And how important is it to have pathologists that really know about vasculitis? Somebody in a sort of community clinic or where they don't see a lot of vasculitis, is the pathology pretty standard and they should be able to diagnose it, or does it require some, pretty in-depth knowledge about how vasculitis can present to make an accurate diagnosis?
I think for some things like the kidney, probably okay. I think the skin biopsies can be challenging. Whenever there's doubt, we always get the pathology slides for review here, especially if the histopathology doesn't fit with the clinical findings. And also increasingly, sometimes pathologists just put a diagnosis rather than a description. And that's something I always want to see as a description of what findings they're seeing that allowed them to come to the conclusion, because we've seen things like giant cell arteritis, and then the description is of eosinophilic infiltrates, which is not a primary giant cell arteritis. It's a temporal arteritis, but by a different process. So for me, it's also helpful to see the description that they provide.
Super. And I've certainly had referrals where patients are sent to rheumatology because they have positive ANCA serologies that may be checked for a wide variety of reasons. How do you think about interpreting ANCA serologies, and how specific are they for ANCA vasculitis?
That's a challenge I face all the time.
Great. That's why I wanted to talk about this.
Yes, that's always the challenging one, especially if the indication was not clear. So, all of our rheumatology tests are always interpreted in the clinical context. So, if you're going to just test serologies, you're going to get false positives. And that causes a lot of anxiety, both for patients and physicians. So, I do have a lot of people that I follow who've come in with these ANCA serologies. They don't have anything that sounds like ANCA vasculitis, but there's always the possibility of renal or organ involvement. We don't know if this is preclinical or just a false positive. I always try to see if there are any medications that you can consider might be causing it, any drug use, especially things like cocaine, that kind of history, and then just a good exam. And when there's uncertainty, you just discuss it with the patient and follow them.
Yeah. And in thinking about vasculitis, I often struggle. It's like, well, is it vasculitis or not? But in the thing that's not, like, what are the mimics that you always have to keep in the back of your mind that you make sure that you sort of consider when you have a new patient in your clinic?
Yes. So mimics would be things like, again, medications like minocycline, hydralazine, PTU. You always want to think about other autoimmune diseases. I mean, we have patients with rheumatoid arthritis, lupus, other autoimmune diseases that can have ANCA serologies. And then also drug use and infections. They're a big one because they can also look like vasculitis. These are patients who are unwell with constitutional symptoms, rashes, multi-system organ involvement. So infection is always a big one that you don't want to miss, especially given the treatment.
Yeah. Are there specific infections that you screen for in these patients?
Yes, so not routinely, but if I'm concerned or they have a clinical picture that's concerning with constitutional symptoms or in their hospital, endocarditis is one of the ones that's been associated with a lot of antibody formation, including ANCA serologies. And then the subclinical endocarditis, especially with Bartonella, has been associated with ANCA and Q fever, or Coxiella with cryoglobulinemia, ANCA, other forms of vasculitis. And I have been burned by these infections, yes.
Wow, fascinating. We wanted to sort of bring you here to discuss some of the challenges of like diagnosing and managing patients with vasculitis. I think one of the biggest challenges that we face is that very sick patient in the ICU that maybe has like pulmonary renal syndrome, and maybe the serologies are positive, or we get a kidney biopsy that suggests that they have an ANCA associated vasculitis. Our first thinking is like, well, do you give them rituximab or cyclophosphamide? How do you think about that decision? What I've seen sort of in my limited practice is that over time, people are getting more comfortable with rituximab. But are there still times where you reach for cyclophosphamide as your preferred induction agent?
So I would say for the most part, people are good with rituximab. That is my choice. If there is a nephrologist or a pulmonologist who's very concerned about the patient in the ICU with very severe disease and their preference is cyclophosphamide, that's certainly something we discuss. It does have a faster mechanism of action than the rituximab, so that might be one advantage. If you're concerned for concurrent GBM disease, then really cyclophosphamide is probably the choice because the rituximab doesn't have as much data there. But these are all things that we have a discussion with the other specialists depending on the organs that are affected. But I would say for the majority, rituximab is really a good medication. For those with relapsing disease, rituximab would be superior.
Interesting. Do you ever think about using both?
So the nephrologists and our lupus people keep asking me these questions. In general, I do not. Yeah, just increased risk of infection. And most of the time, one of the induction agents works very well. So
Yeah, I know sometimes I see it more in pediatric rheumatology, where either for lupus or even vasculitis, they're thinking about combining both cyclophosphamide and rituximab. I don't know that that has any sort of superiority of using versus using one or the other. And then the other question that always comes up is, do you do plasma exchange? And I know that there's been some studies that suggest that maybe it doesn't help, but it depends on your patient population. Are there patients that you consider doing plasma exchange as part of their induction treatment?
Yes, so not routinely, but definitely in, again, the subset with GBM, there is a role for plasma exchange. We don't want to miss that because there are some people who can have concurrent ANCA vasculitis with GBM disease. And then someone who's doing poorly, so, they're not responding to your induction therapy with steroids, they're very sick in the ICU. For renal involvement, yes. For alveolar hemorrhage, probably not much role, but there is a meta-analysis, even though the large clinical trial didn't show any benefit of plasma exchange in outcomes like end-stage kidney disease and death. Meta-analysis showed maybe there is some benefit in people with severe renal dysfunction in terms of end-stage kidney disease a year later, but that's also associated with increased risk of infection. So it's just kind of a decision we have to make.
Yeah, it's so hard to make those decisions because the patients are often very, very ill, and you kind of want to try to do everything, but realizing that if you do a lot, that also has consequences, like you mentioned, infection risk with plasma exchange. And then, of course, we have to talk about the new player. I think it was 2021 when avacopan was approved by the FDA. I think it stated for use in combination with standard therapy to treat adults with severe ANCA-associated vasculitis. Is it your practice now that you give avacopan to most patients with AAV, or are there patients that you think shouldn't get avacopan?
Yes, so avacopan, the C5a inhibitor, has been approved as an adjunctive therapy, so patients should still get induction therapy with rituximab or cyclophosphamide. I do like this medication for anyone with renal insufficiency or renal involvement because there is data showing better renal recovery compared to your glucocorticoids. I do consider it in people where I really want to taper the glucocorticoids rapidly because of comorbidities. I'm not using it routinely in all patients with newly diagnosed disease. I do use it in patients who are having challenges despite conventional immunosuppressive therapy. So I have someone who's on rituximab every 4 months, the 2 doses, plus methotrexate, plus avacopan, and that's the only way she was able to get off her prednisone. So I do select patients who might benefit from it. And the people who should not get it is people with liver dysfunction because of concerns for liver toxicity.
Yeah. So for instance, I saw a patient last week with isolated sinus disease, ANCA negative vasculitis. So in the past, she's done very well with rituximab treatment. So I was going to retreat her again. But I guess maybe that avacopan may not benefit her. And certainly there's little evidence for using avacopan for isolated sinus diseases. Is that
I would say
your
we don't
thoughts?
have enough data. I think we'll have more and more data on the subsets, but like, do they work for the granulomatous manifestations or the limited disease? And then the other interesting role for avacopan really is in preventing relapses. So in the clinical trial, at 1 year, there were fewer relapses in the group treated with avacopan compared to glucocorticoids. So that might be another role to clarify is it actually helpful for maintenance or prevention of relapses long term?
Super. You mentioned that when you're thinking about tapering steroids, that avacopan may have a steroid sparing effect. How do you think about steroid tapering in patients with ANCA associated vasculitis? I think we're all trying to, use less steroids. Was wondering if you have thoughts about how you manage steroid tapering in these patients.
Yes, so less is always more with steroids. I think we've all learned that. One, the patients don't like all of the side effects, but also there's a lot of data about infection risk and other side effects related to the glucocorticoid exposure, especially in patients with ANCA-associated vasculitis. So I do use the reduced taper that was in the PEXIVAS group, and that is the recommendation from the societies as well, including the American College of Rheumatology and Vasculitis Foundation guidelines and also EULAR's updated recommendations. I do follow these patients very closely, especially when you're tapering your glucocorticoids rapidly. I'm still a little nervous about them, especially ones with severe disease, but I just follow them closely.
Okay, good. I'm glad that you brought up the guidelines because probably a couple of years ago, we did episodes on all of the new guidelines to manage vasculitis. So if anybody's interested, we'll put the links on the show notes for those episodes. I think those were really interesting to discuss about how the guidelines came to be and sort of the recommendations as it stood, I guess, a couple of years ago. I'm sure these things are all in process of revision as we have new data and new medications that come out. And the other question that we often face is like, okay, you have somebody with ANCA-associated vasculitis. They were induced with rituximab and let's say avacopan and steroids, and now they're just on maintenance with rituximab. And how long should you continue their maintenance for? Is there a point where you just stop infusions, or what's your plan?
Yes, that's another challenging question. We're lucky that we have agents that actually maintain remission in these patients, and rituximab, I would say, has really been a game changer compared to patients who used to be on methotrexate, azathioprine, CellCept, mycophenolate mofetil, Flair, and then you were just cycling between the three. So I would say rituximab has really changed that. I treat most patients for at least 2 years, and then the ones that have had multiple relapses are ones that are probably going to benefit from long-term immunosuppression. People who have severe renal disease and the risk of a flare would tip them over into dialysis, for example, might be people to keep on treatment for longer. We know patients with PR3 ANCA and relapsers are going to be relapsers again. So those might be patients we want to consider treating for longer. But oftentimes these days with the newly diagnosed patients, they're in remission for the entire time that they're on rituximab. So that makes it a little challenging. So I do give them the opportunity to come off their medications. There are different strategies. There are some people who taper out the infusions slowly. So maybe instead of every 6 months, they're going every 7 months, etc., to see if patients are having any issues. In some patients, we'll just discontinue therapy and then monitor closely, follow B cells, ANCA levels to decide. I don't treat just based on numbers alone. I always ask the patient if they have a preference. If they say, nope, they just want to stay on treatment, they're worried about a relapse, that might be something to consider as well, especially if they're tolerating the medication well. But those are usually the ones who are relapsers, where I give them the
Got it. So
choice.
you do check B cell levels and ANCA levels, but don't necessarily restart treatment just for those levels. Are you also looking to see if they have signs or symptoms or other things on their labs to indicate active disease?
Correct. Yes.
Mm-hmm.
And how they're feeling as well. Yes.
And how did you manage the COVID-19 pandemic in light of all your patients on rituximab? Can you talk a little bit about that experience?
Yes, that was a very stressful experience for almost every patient on immunosuppression, but especially the ones on rituximab, because there's no way to reverse the treatment and the B cell depletion. The recovery, there's no way to speed it along, and different people recover their B cells at different rates, 6 months, a year, or longer. So a lot of discussion with it was challenging when the vaccines came out, with realizing that they may not get protection from the vaccines, although there was some data suggesting the T cells were able to respond to the vaccines. And then thankfully we've had treatments now with the Paxlovid. I don't remember the generic.
Yep.
So at least we have ways to help them, and that has been associated with decreased risk of hospitalization and severe complications. And then also the new treatments that have come out for pre-exposure prophylaxis. I know there have been different versions of it, but these are ones I strongly advise all of my patients to get in addition to the vaccines.
Got it. So in the ideal world, before starting rituximab, you have them get vaccinated, and then you give pretty much, or you offer all of them the pre-exposure prophylaxis?
I do.
Okay.
I do.
That's great. That's a great reminder. Actually, one of my patients, maybe a month or two ago, mentioned to me, is like, hey, can I get that new pre-exposure prophylactic agent? I'm like, Evishield, like that's been out of commission for a while. It's like, no, there's a new one. And yeah, there's, I think it's Pemgarda. That's right. So it was great for him to remind me about that. And yeah, I think patients on rituximab seem like ideal candidates for that.
Yes, and they're also counseled on contacting us immediately if they So if they have respiratory symptoms, they need to test for COVID because we do have treatment for COVID. They should contact us immediately because sometimes the young patients, the physicians in the community or their primary may not realize that they're actually sick, immunocompromised patients who should be offered treatment. And then also we've had a few that have needed IV remdesivir and other treatments as well because they just don't clear the infection as well.
Yeah. I always wonder when people have, you've sort of built your career around vasculitis. How did you get started and how did you get interested in vasculitis? Can you walk us through your path about how you currently sort of lead the Vasculitis Center?
Oh, yeah. So it actually started in medical school. I did a rotation in rheumatology, and I still remember my first patient that I saw was a patient with GPA who was started on treatment with cyclophosphamide. And I've just been fascinated with that. Started my quest in terms of rheumatology, autoimmune diseases. But then while I was at the Mayo Clinic, I had the fortune of working with Ken Warrington, who was my mentor, now colleague. And they had a vasculitis clinic where I spent time. And I just found the diseases very fascinating, in addition with all of rheumatology. And that's where I started my interest. And then there was a fellowship that was available through the Vasculitis Clinical Research Consortium with Peter Merkel as the principal investigator. And I did a 1.5 year fellowship in the VCRC. And that's how I got started on my career. And then no one was doing vasculitis here at UCLA. So when I moved, that's what I chose to focus on because of my background. Yep.
What would you say to trainees, whether medical students, residents, or even fellows that are interested in vasculitis? How should they think about pursuing their interest in becoming vasculitis doctors?
Yeah, so thankfully our community is growing. So there's more and more people who are interested in vasculitis. So I would say identifying a physician who sees a lot of vasculitis or a center that has tertiary evaluations and referrals for vasculitis and spending time there. We're a very close-knit community. We're all very collaborative. We have to be. These are very rare diseases. So I would say just expressing your interest, identifying people who would be able to guide you. And I like vasculitis. We've had a lot of good treatments. We can get our patients into remission. They do well. The challenge is always the diagnosis.
Yeah. And can you talk a little bit about sort of the role of registries in trying to advance the field forward?
Yeah, I think those are very, very important. So we have the VCRC. Then we also use a lot of the clinical trials to, identify a lot of important questions later on. And then there's also the Vasculitis Patient-Powered Research Network, which is actually patient-driven, where patients don't have to be near a vasculitis center. They can go online. They do enter their own information about their diagnosis and other factors. And then a lot of people who are interested in research, investigators in the community, can also work with those patients, or patients can opt into studies that are available. There have been things about disability in vasculitis, sleep disturbance, all sorts of interesting studies that have been done with the VPPRN.
Wow, that's amazing. As a clinician that evaluates and manages patients with vasculitis, what do you think is the biggest unmet need for these patients?
For me, it's really the diagnosis. There's so much delay in diagnosis that it's really a shame because we often catch the patients after they've had damage occur. So when you think about Takayasu's arteritis or even ANCA vasculitis, where they've come in with kidney failure, and when you hear their story about how long they've been going, complaining about some of these symptoms, or seeing multiple urgent cares, primary care physicians, ER visits, etc., before the diagnosis is realized, I think that is one aspect that I would like greater awareness, greater framework in terms of how to catch these early before the damage occurs. I think some of it is just thinking about these diagnoses. They are rare, and more common sinus things would be allergies, etc., not GPA or vasculitis.
Right.
But still, when patients are not responding to your treatments or there's other systemic things going on, thinking about these diagnoses early.
Awesome. Tanaz, anything else you want to share about vasculitis, whether it's about diagnosing or managing these patients? Anything you've learned over the years?
Yes, so I think rheumatology in general is very humbling. So I would say, listening to your patient, doing your due diligence with all of the testing, evaluations, working with the other specialists. We can't be the experts of everything. So one of the things I do is share my patients with the other subspecialists, talk to them, get their input as well. That's how we learn as well.
Awesome. Tanaz, this has been a wonderful conversation. I think you've certainly cleared up some of the challenges in diagnosing and managing patients with ANCA-associated vasculitis. And I hope that listeners out there also took away some of your knowledge that you've gained from, so many years specializing in this field. So thank you so much for your time.
Oh, thank you. It was such a pleasure.
That's it for vasculitis. I hope this episode offered you some fresh insights into the diagnosis and management of ANCA-associated vasculitis. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, watch out for those blood vessels. And of course, stay healthy.